Hey everybody, welcome back to our EKG of the day. My name is Reed, and if you enjoy these videos, please feel free to subscribe to the channel and join me in the journey of EKGs. So let's get into this one. So this is a 12 lead here, and this is a pretty fun rhythm. And so what I like to do initially is look at the forest, and the trees of the forest are my QRSs. And so I'll start down here, maybe on this bottom strip, and I'll see we've got these narrow complex QRSs that are occurring quite regularly, and they're occurring at a rate of, let's see here, say we'll start at this one. We've got 300, 150, 100, 75, 60 beats per minute, 60 beats per minute. They're all occurring exactly 2 small boxes from that thick line. This is a perfectly regular rhythm where all the QRSs are lined up exactly at 60 beats per minute. And when would we see something like that? Well, luckily we have what I call, this is a joke, the arrow sign. The arrow sign. Thank you for this EKG machine for pointing out these pacing spikes. And so if you notice, this person has got a pacemaker. And so we've got these pacing spikes throughout. But notice these pacing spikes do not come before the QRS. They're coming quite a bit prior to the QRS. They're actually atrial pacing spikes. They're atrial pacing spikes. If you notice, if I zoom in, say on lead 2 here, we've got our pacing spike occurs, and then you'll notice right after it, we've got a P wave. So that's how you know it's an atrial pacemaker. And then this person has a healthy AV node. It's healthy enough, we'll say, to conduct to our QRS. So this person AV node is working good enough. However, I would venture to say that if you look at our PR interval, which is from the pacing spike to the beginning of the R wave, I would say that is about 240 milliseconds. So they do have a first degree AV block. I know it's a first degree because my PR interval is long. It is greater than 200 milliseconds. However, every single P wave conducts to a QRS. If I look at all of these P waves, they're all conducting to QRS. None of them are being dropped. And so that's a first degree AV block. But we're not done yet, because we need to go ahead and determine, well, what's going on with my QRS? Well, my QRS is upright in lead 1. It's upright in AVF. So that is a normal axis for my QRS. When I scan through the precordium, I do notice that maybe in V1 here, I've got a little bit of a RSR prime, which usually RSR primes in V1 is a right bundle branch block, but we said our QRS is narrow. So RSR prime plus narrow QRS equals an incomplete right bundle branch block. So the last thing we're going to do is we're going to scan through our anatomical regions, inferior, lateral, septal, anterior, and just take a look for any ST or T wave changes, any deep Q waves that might indicate a previous infarction, and we don't see that. So what do we conclude with this rhythm? We've got a regular rhythm with atrial pacing. It is conducting with a first degree AV block, and we have an incomplete right bundle branch block. And so this is a great example of why I like to approach my EKGs from an anatomical standpoint, where I understand the electrical conduction, and we can be able to tease out all the little things that are subtle with these EKGs. So I hope this helps, and I hope this helps you understand the different types of pacing and gets you more repetitions. In this case, in somebody who is being atrial paced, we might see atrial pacing in somebody who's maybe you got a sick sinus syndrome or a sinus node that doesn't work really well, right? If their sinus node is working, we wouldn't need to pace the atrial for them. So think through things like that as you're kind of trying to apply these EKGs to your clinical experience. So have a great day.